Okay, thank you so much. So guys, do you want to be a bad one or a badass one? It's not about individuals, though. It's about systems. And we need to have our system on a level of excellence. So what is the future? We've talked about ECMOs and RIBOAs and stuff like that. Back to basics. What are our patients that we're about to resuscitate? We talk about sudden cardiac death. We have over 50% of our patients actually having signs and symptoms saying that they are going to be in an arrest. What do? We don't have that in our chain of survival, should we? The anticipation, prevention of cardiac arrest. We don't have any risk identification tools. So we need more people staying up late nights and weekends to find out how we can predict that this person is in real danger of getting a cardiac arrest. We are not similar. We've seen pictures before. And we still do one fit all in training, in our algorithms. We need to change that too. My very favorite president of USA, not the one we have today, has said that one size doesn't fit all and we need to have a precision medicine. And I really think that we should do more of that also when we resuscitate. This is to just show you that Finnish people do good research in resuscitation. Sanna and her group has shown that not everybody gets higher blood pressure even if you compress deeper. Just to say this is one of the many studies showing that we are very different and we still don't know what are the individual markers of how we resuscitate. So, culture of excellence is a choice. You need to choose to be something extraordinary. And I would say that there's not one single system in the world at this moment that are actually really excellent. Even Seattle has things lacking that they could have in to make a better job. So we probably all have some paths to travel. What are the most important things? Never say that we've done that, it didn't work. Or we've always done this, so we just keep on doing that. Never do that. Just try to think out of the box. There's a lot of new things, or picking up the old ones. Try and find a way. And don't do it for yourself, not as a researcher, not as a provider. Do it for your patient. This is from the formula of survival. You can see that we save around 20% of all cardiac arrests in our best systems today. That's not very good. We still lack a little bit of evidence, more research. We still lack education. That's probably the easiest way of getting your culture of excellence closer, is to change your way you educate your providers. And then, of course, local implementation is usually the weakest link in the chain. We have good science, we have young people coming with a good education, but then we do something wrong and we don't implement those in our normal everyday life. So, today we talk about the formula of survival, we talk about the chain of survival. As part of that, we need to start thinking about the system around those chains and formulas. And that means that we need to have leadership, training, quality improvement to have a culture of excellence. So it's more than just following an algorithm and have good training. We have programs today. We have 10 steps from the Resuscitation Academy in Seattle. Is going all over the world. We have one in Europe, there's one in Korea, in Japan. And around these resuscitation academies, there has been now a global alliance initiative, which means that ILCOR brings you the science, the global alliance implements that science into the EMS systems all around the world. So here's a little pic of my studies. They're all very old, and I still don't see that something has happened with these issues. The first one is about the attitude. What would you think would happen to one of the red guys in the picture if they would hesitate 1 second to change the bolt in the car or open a screw so that somebody can change the tire? Still, in my study, we could show that people in EMS, nurses, 15% hesitate to start CPR because they think they harm the patient. Harm a dead one? 21% don't want to start defibrillation because they think that they're doing something bad. And hesitation means time. So they're actually harming the patient by not starting. The picture behind the 2 little cute dogs, which will show you that we need leadership even if we have only 2 persons at the scene of a cardiac arrest. My study with Swedish and Finnish students showed that the pairs that actually had a leadership defined by whoever grabs the defibrillator is the leader of the situation got much better points than those that had exactly the same training, exactly the same skills, but they lacked the leadership. And the last study, which is also very old and so far the only study ever looking at how professionals act when they call 112. Group 1 is doctors and nurses. They have the worst survival rate. They have the most unexpected deaths. And in those patients that they called 112 and told the dispatcher that we have somebody who's sick, one person was asked to have a transport to another hospital because they thought that the patient couldn't be treated in that hospital. That person had signs of secondary signs of death when my crew came to the hospital. So the weakest link of the chain might be very much different from what you think. We've heard about the importance of the laypersons in trauma. We need to also focus on our professionals. So we should be feeling that we're in the same boat. We have one system and all the parts of the system has to function. Otherwise the boat will sink. And it doesn't help if you're laughing at that point. In 10 minutes you're also under the water. What happens when you really start to do what you're supposed to do? 16% survival rate, 38 with normal following algorithm training, blah, blah, blah. Then you do something, you take a course, you start to think of your system, and you're up to 55 and racing. They are up to 57 this year. So Ticino in Switzerland could do it. I'm sure you guys can do it too. Thank you.
Thanks, Maaret. So we've time for a couple of tweet questions.
Yeah, as far as the diagnosis of cardiac arrest, it's one thing if someone's in front of you and goes down, but say you have an unresponsive patient in your ED or a trauma patient, in the idea of losing pulses, how accurate is the idea of palpating a pulse with your fingers? How accurate is it to actually diagnose cardiac standstill or cardiac arrest in especially like an obese patient versus, using POCUS or ultrasound?
Yeah, we have a very good, very old study showing that professionals, when they were led into an operating room with the cardiac surgery where the patient actually went on a bypass machine, so no heart function, right, absolutely no pulse, that they couldn't do it. And that's why when we changed the guidelines to actually say that you don't check the pulse. So there's very good evidence saying that it's really hard to do it, even if you're not obese.
Yeah. Good question.
Dr. Castren, you talked about the chain of survival. In the US, there's a high variability based on your outcomes depending on where you are, and a lot of that has to do with bystander initiation of CPR. In Europe, what are your best practices to educate your community and citizens on initiating CPR?
Yeah, we know that the campaigns of getting people to do the right thing, they do something and then it goes down. So it's not a long life thing. If I would choose where to put my money, I would put it in the dispatchers, because everybody who's saved calls 112. And it's very good if you're trained, but if you're trained like as an 18-year-old, and this happens when you're 26, you probably need very good guidance anyway. So I would put my money on the dispatchers and see that they do a rapid dispatch with fast starting, no taking clothes off, no checking anything. If patient doesn't react, just start. They will tell you that, stop, I'm alive.
Yeah.
If it's not in proper place.
And there's an evidence base to support that now. Janet Bray in Melbourne showed that the instigation of telephone-assisted CPR improved outcomes. More people left hospital afterwards.
Yeah.